Our speaker is extremely qualified. There's Dr. David Newell, who was born in Massachusetts, raised in that state. He obtained a medical degree from Case Western Reserve University in Cleveland. He completed his residency in neurosurgery at the University of Washington. He was a Van Wagenen Fellow in 1989 and spent 1 year at the University of Bern in Bern, Switzerland, with a professor who was developing methods to measure cerebral autoregulation non-invasively using transcranial Doppler. He was a recipient of multiple National Institutes of Health grants and awards. He's published nearly 200 articles and has written many chapters and edited 4 books. He is one of the original authors of the Guidelines for the Management of Severe Traumatic Brain Injury, published by the Brain Trauma Foundation in the Journal of Neurotrauma, and Surgical Guidelines published in Neurosurgery. He served on the faculty at the University of Washington School of Medicine for 15 years. He was formerly chief of neurosurgery at Harborview Medical Center and professor of neurological surgery at the University of Washington School of Medicine. He's currently co-executive director of the Swedish Neuroscience Institute in Seattle, Washington, which has an active fellowship program in clinical and basic research. He specializes in microsurgical treatment of the spine and cerebral vascular systems. He's also specialized in the expertise and treatment of cerebral aneurysms, AV malformations, and in stroke and carotid surgery. He currently resides in Seattle, Washington, with his wife and 2 children. Dr. Newell. Correction, Yep. We still, what, CME? Oh. 2 things. We would remind you to be sure and drop off your CME sheet when you're done with it at the end of these 2 sessions. And also, just a reminder, in case somebody wasn't here when I announced that a select stimulator for muscle stimulation disappeared over at one of the vendors' tables. It's in a black pouch. It's a rather valuable thing, and they just see if you inadvertently picked it up. Just check your articles and see if you have that. Thanks. Dr. Newell.
Thank you very much for the kind introduction, and I'd also like to thank Mark Johnson and Ron Dallaire, who invited me here to give this talk. I was back here in 1994, I guess, for the first experience at the Ogden Medical and Surgical Society, and I enjoyed my stay back at that time. Today I'd like to talk about mostly cerebrovascular aspects of neurosurgery and what's new in neurosurgical approaches to hemorrhage and stroke in the brain. Just to do a quick review, if you remember, let me find the pointer here, all the causes of stroke here, about 85% are caused by infarction, and 60% of those, 60% are cerebrovascular atherosclerosis, usually large vessel atherosclerosis in the North American population. About 20% of penetrating artery disease or lacunes. About 15% come from cardiogenic embolus, and then about 5% blood dyscrasias, hypercoagulable states, and so forth. And then about 15% are due to hemorrhage, and those are intracerebral hemorrhages and subarachnoid hemorrhage. So as neurosurgeons, we get involved in these especially, and also the ones with carotid surgery that result in these kinds of strokes. And there's some new exciting things coming out, and I think our involvement in stroke now is going to become multi-specialty and multidiscipline. Now, if you remember, most of the middle cerebral artery strokes, the hemispheric strokes, are due to a blood clot that lodges either from a large artery or the cardiac embolus. The ischemic stroke produces a core of tissue damage, and then there's this been this research area that has been around for the last 20 years that's described as penumbra or idling tissue, and the goal has been to try to save this because the core of the infarct is destined to become permanent, but there can be tissue to be saved here. And we've gone through a whole decade and a half of research on neuroprotectant agents to try to save this idling tissue, and it's been somewhat disappointing. All the glutamate antagonists and other medications to try to provide neuroprotection have been disappointing in clinical trials. The big area now that has come to fruition is thrombolysis, get the clot out of the middle cerebral artery, and this approach has resulted in some dramatic results in ischemic stroke, and there are some newer strategies now with some of the newer techniques to take this a little bit further than the IV TPA, which is the standard treatment. As you remember, large vessel atherosclerosis in a Western population is usually the result of carotid bifurcation disease. These are very well detected with ultrasound screening and so forth. And there's usually an artery-to-artery embolus that lodges up into the middle cerebral artery. Once the patient has had a stroke like this, if they recover reasonably or if it's just resulted in a TIA, the strategy is to treat the lesion here. And the treatment is still carotid endarterectomy at this stage. This has been shown in multiple NIH trials to be beneficial, over 50% stenosis in symptomatic patients, and asymptomatic patients, a higher degree, about 70% stenosis, not as effective in women, and the effect is not as great, but very effective in symptomatic patients. One of the newer methods has been stents that's challenged carotid endarterectomy. The stents initially were shown to shower quite a few emboli, and now the newer stents have little umbrellas or embolic protection devices. And the CREST trial comparing head-to-head carotid stenting with carotid endarterectomy is still ongoing. Most practice nowadays, I think that the stents are reserved for patients that have unstable heart disease, and the carotid endarterectomy is still a treatment of choice, although again we're having to wait for the CREST trial to get a final answer on that. The other source of infarction is, of course, the lacunar infarction, which comes from hypertrophic changes in the small penetrating arteries. These usually result in small lacunar infarctions that result in transient motor or sensory symptoms. If you get enough lacunes, you can develop a pseudodementia type state. Often they're in the brainstem also, causing focal neurologic deficits there. The only real treatment that we have here is prevention of further lacunar infarctions by primary hypertension control. Cerebral embolus, as I mentioned, that comes from non-atherosclerotic large cervical arteries, can come from multiple sites, including the heart, patent foramen ovale with DVT, paradoxical embolus. The heart is a big source of emboli from a bunch of different pathologies. But when the artery goes up and does lodge in the intracerebral arteries, then we have an acute ischemic stroke, and we can search for the cause afterward, but the primary goal becomes how do we treat that stroke. So as you know, intravenous TPA within 3 hours is the standard treatment for an acute ischemic stroke. This shows a clot lodged in the middle cerebral artery. This is a CT angiogram showing the two internal carotid arteries, normal middle cerebral artery, and then one that's interrupted with clot here. If the problem with the IV TPA at this point is about only 8% of patients really get in within the 3-hour time window to be treated and triaged appropriately to get their IV TPA. So it's a bit disappointing in terms of the effectiveness, overall effectiveness in the population for this treatment. The other newer therapy that's come along is intra-arterial clot lysis with several different catheter designs, and that's in current practice reserved for patients that don't get in within the 3-hour window, And if they're 3 to 6 hours, there's a study looking at various catheter designs to try to retrieve a clot from the middle cerebral artery or the internal carotid artery to try to lyse the clot, again, with the goal being to restore the circulation in a timely fashion. Now, some of the catheter designs include this Misti device, which is like a corkscrew that goes around the clot and tries to pull it out. It's successful in a significant percentage of the time, but not 100% of the time. And then there are other potential problems, including damage to the endothelial because the clot is adhered and so forth. Other attempts have been to use an ultrasound catheter where the ultrasound catheter is placed up into the clot, and ultrasound plus TPA is given to try to lyse the clot a little bit more gently and gently detach it from the endothelial. This is an Echos catheter device. Echos is a company in the Seattle area that makes these microcatheters. The other thing that this has been useful for is deep venous thrombosis and pulmonary emboli, and it's based on the fact that there's a newly or recently observed phenomenon called sonothrombolysis, and the fact that ultrasound works in combination with TPA to dissolve the clot a lot faster than either therapy alone. So what could be some of the next steps? Well, as I mentioned, the sonothrombolysis phenomenon has been well documented in laboratory experiments, whereas if you take a piece or a collection of clotted blood, put the TPA in alone or the ultrasound alone, and then put the combination of the two, there's a much more robust effect of clot lysis by adding ultrasound to the mix here. And this just shows a preparation where this is time 0 of the whole clot. This is the tiny ultrasound catheter, and after 35 minutes, the clear zone is where the clot is lysed. After 60 minutes, the clot is lysed in a much, much larger zone. And again, this is a very robust biological effect. It's thought that the ultrasound leads to an increased zone of binding of the TPA throughout the clot and lyses the clot a lot faster. So some of the new therapeutic aspects of ultrasound thrombolysis are including externally beam focused, direct catheter, as I showed you, focused, and then for intravascular clot lysis. And then a new application that we're studying now is actually for intracerebral hemorrhage, and I'll tell you a little bit about that with intracerebral clot lysis using this technology. Well, as was mentioned in the introduction, I became interested very early when this technology became developed, Transcranial Doppler, and I did go to Switzerland to study this when I first finished my training. And this was a method that was used to look at, it was assumed that the ultrasound that we all use for peripheral applications in the neck and the extremities and so forth would not be useful in the head because of the bone, but somebody figured out how to adapt this to intracranial uses. So the transcranial Doppler became a way to measure ultrasound flow in the intracranial arteries. And so one of my first research projects was to use this for vasospasm, which happens after ruptured aneurysm. And as you can see, this is a artery that's normal after clipping of an aneurysm with normal velocities. And here's the artery after it's gone into severe spasm with marked increase in the velocities of the blood flow. So this became very useful as a non-invasive way to monitor vasospasm after subarachnoid hemorrhage. One of a researcher named Andrei Alexandrov down in UT Houston was using transcranial Doppler to try to see in patients that got TPA how long did it take the artery to recanalize and the clot to break up, because nobody had really studied that phenomenon. It was just the approval of TPA was just based on the observation that the patients that got it in 3 hours had an improvement in their Rankin score and NIH stroke score, but there was never good documentation of whether the artery actually recanalized and the thrombus broke up. So he was doing a study to look with TCD, which was a natural way to look non-invasively in the brain to see when the artery reopened after the patients were given TPA. And the nurses commented, hey, these patients are getting a lot better faster than in the TPA trial that you're examining them with ultrasound. So light bulb went off, and he went on to do a study to show that if you use just diagnostic doses of transcranial Doppler on the clot using ultrasound, you could more than double the recanalization rate with intravenous TPA. And the other development that's come along to add to this story is if you give these small microbubbles that are used as ultrasound contrast agents, when they hit the ultrasound stream here, they break up into smaller bubbles and cause an increased agitation effect and aid in the breaking up of this clot. So focal treatment in addition to the regular intravenous TPA. So there have been now 414 patients studied with 6 randomized trials and 3 non-randomized trials showing that if you just give the TPA, just like they did with the NIH trial, you get about an 18% recanalization rate of the middle cerebral artery. If you add the ultrasound plus microbubbles, that goes up to 40 to 50%. So it more than doubles the recanalization rate, and in small studies there is an improvement in outcome there. So the NIH said, well, we'll only fund this if you don't have to actually stand there for 2 hours and hold the probe on somebody's artery in addition to the TPA. So a new company has been formed to make an operator-independent device here, which has multiple probes that will focus the ultrasound on the clot and leave it there for 2 hours in addition to the microbubbles and the TPA treatment. So this is funded by the NIH now to go on to safety trials using a new transcranial Doppler device that's not just designed for diagnostic purposes but designed for treatment purposes. So I think this is going to be an exciting area in the future, because I think the name of the game is to increase the effectiveness of this treatment, possibly extend the time window and get more patients in a timely manner, more than 8% at least with acute ischemic stroke, to get in for this potentially valuable treatment. Now, I just wanted to go on to intracerebral hemorrhage and also mention the same sonal thrombolysis effect that we're kind of excited about as a potentially new treatment for intracerebral hemorrhage. As neurosurgeons, as you know, we often deal with people with bleeding of in the brain from various surfaces, from various causes, mostly traumatic, but also the spontaneous hemorrhages. We see all those patients that come in as a consult and occasionally have to take them down to surgery to evacuate these spontaneous intracerebral hemorrhages. Trauma, as you know, I won't talk about today, but just as you know, I wanted to mention the various causes are epidural, subdural, intracerebral, and subarachnoid hemorrhages due to traumatic injury to the brain. And spontaneous hemorrhages, the most common, as you know, are these primary hypertensive hemorrhages. And then we're always called as neurosurgeons to rule out any kind of structural lesion, a vascular lesion, and particularly an arteriovenous malformation, an aneurysm, a vasculitis can also be a cause, tumor, older individuals, amyloid, and then in some patients there's no structural lesion, but they're anticoagulated, so coagulopathy can cause bleeding in an otherwise normal brain with normal vessels, or some patients can have an altered physiology where they have sudden high changes in blood pressure which can damage a normal circulation and cause breakthrough and cause hemorrhages. So the primary hypertensive hemorrhages, they've been frustrating to treat because the locations that they occur in often cause significant damage to the deep portions of the brain. So even if the patient doesn't die from pressure effects, the damage to the brain is often severe, and they'll be at best hemiplegic when they recover from the primary hypertensive intracerebral hemorrhage. There was an NIH conference that was convened about 6 years ago to look at the fact that no good studies have really been done on treatments for intracerebral hemorrhage. And so they identified two areas of possible opportunity to study intracerebral hemorrhage, and the two main recommendations from the panel were to study blood pressure management and also look at minimally invasive therapies to try to evacuate the intracerebral hemorrhage. Again, this is the old Netter diagram showing all the different locations, as I just showed you, the basal ganglia, thalamus, brainstem, and cerebellum, because all these locations in the brain share these small perforating vessels that are usually the cause of hypertensive hemorrhage. One of the facts that has come out here is that the ICH volume is a powerful determinant of the outcome. So once you get over 30 cc's, the bad outcomes go up significantly after that volume. The underlying cause is thought to be from these small perforating arteries, and again, these Charcot-Bouchard aneurysms were described in the late 1800s off these small perforating arteries, and these arteries can become damaged from chronic hypertension changes and rupture and cause these lesions. So as neurosurgeons, we're called to see these patients every time they come in with blood in the brain, and our job is initially to rule out a structural and vascular lesion as a cause of these, and the management of primary hypertensive hemorrhage has not been changing much until recently, and I'll share with you some of the new trials that have been done. Some of the advances that are being made now are in imaging. We were one of the first institutions to get one of these Ceratome, which was a smaller CT scan that just admits the head. It's portable. You can bring it into the ICU or down the operating room. I think in the near future it's going to end up probably being in certain ambulances that are geared toward neurocare, and I think in the future, if some of these other therapies, such as the ultrasound thrombolysis, become effective, you can imagine getting a scan when they pick up the patient, and all the information can be transmitted with broadband communications to a site to read the scan, and a lot of this diagnostic workup can be done to try to get patients in earlier to try to solve this problem. They can do this is a CTA that's done on one of these Ceratome scans to rule out an aneurysm and rule out AVM. Those are the main things that we try to do early on. And if in the case of acute ischemic stroke, one of the first steps in deciding whether you give TPA is to make sure it's not a hemorrhage that's causing the hemiparesis, and that's one of the first diagnostic studies that needs to be done. So in terms of the primary treatment of intracerebral hemorrhage that's not due to vascular lesions, and I'll go over some of the vascular lesions in a little while here, the main treatment has been stabilization and supportive therapy and to stop further bleeding. It's been recently realized when patients get contrast-enhanced scans when they come in with a primary hemorrhage, about 30% are actively bleeding at the time they're admitted to the hospital. So there have been various strategies to try to address that problem. One is blood pressure control. We were all taught not to lower the blood pressure because of the autoregulation curve becoming shifted in hypertensive patients, but new guidelines are indicating that you should try to get the blood pressure at about 180, and these two trials, the ATTACH and the INTERACT trial, are larger randomized studies to try to lower the blood pressure down to a lower range to prevent this further bleeding of the intracerebral hemorrhage, and the tricky thing is to try to lower it without compromising cerebral blood flow, especially when the intracranial pressure is high. So the ICP-directed therapy, blood pressure control, are some of these supportive measures. Correction of the INR in patients that are anticoagulated. And there was a lot of excitement about factor 7 or Novo 7 because there was active bleeding going on in a large percentage of these patients to try to get that to stop in some way. And then, of course, evacuation, remove the blood. The surgery trials have been disappointing so far, and as I mentioned, the NIH has recommended that one of the more promising avenues has been this catheter or minimally invasive evacuation, and I'll tell you a little bit more about that. And then, of course, risk factor reduction. The reversal of the INR, most people give fresh frozen plasma. Vitamin K takes a couple days to work, but you can give that if they're anticoagulated. And then protein complex concentrate, and this NOVO7 or factor 7 has been subjected to a recently reported large randomized trial. So there were 800 patients that were given NOVO7 for hypertensive intracranial hemorrhage. Unfortunately, the first trial indicated that there would be a benefit. However, on this larger trial, there was a significant reduction in the ICH bleeding in the group that received the NOVO7, and there was initial early improvement in outcome, but their 90-day outcome in mortality did not pan out to be improved. And this was called the FAST trial. It was reported in the New England Journal of Medicine in 2008. As I mentioned, the hemorrhage was the percent increase in the hemorrhage after they came in was slightly reduced in the two dose that were given, but the outcome at 90 days was not significantly different. So at last, Novo Nordisk has not pursued this for approval for use. It's very expensive, as you know, for intracerebral hemorrhage. Surgical evacuation, there were a number of trials done. Many of them were small numbers of patients, and earlier, this one was even before the CT era. The largest trial was called the STITCH study done by Dr. David Mendelow in England, and there was no benefit of surgical removal. This is a meta-analysis showing a slight favoring of surgical removal. And the new trial that is being looked at now is called STITCH 2. And because if they looked at all the subgroups of patients, the ones that seemed to benefit from early evacuation with surgery of the hemorrhages were the ones that were more lobar and not these deep clots. As you can imagine, this makes sense. If this hemorrhage has destroyed all the deep regions of the brain, removing it is really not going to result in a functional patient. So let's select out the ones that have some preserved brain but do have a hemorrhage and are at risk for edema and increasing ICP. So the STITCH 2 trial will be starting soon to look at this subgroup of patients for early surgical removal. Now, as I mentioned, this minimally invasive approach has been another promising avenue for investigation and has been supported by the NIH with funding directed toward this endeavor. And there are 3 studies. This CLEAR study is mostly for intraventricular hemorrhage, which has been a frustrating condition to treat, and then minimally invasive surgery for intracerebral hemorrhage. These are the parenchymal hemorrhages, and this is a study that we're running now at our center called the SLEUTH trial, safety of Lysis with ultrasound and TPA of the intraventricular and intracerebral hemorrhage, and I'll show you several cases that we have, early cases from this trial. Well, the CLEAR study, as many of you may know, when you see these patients, the ones that have a small a basal ganglia hemorrhage that break into the ventricle, and most of the hemorrhage goes in the ventricle, there's actually not a lot of brain destruction, and they can often be awake when they come in, and they deteriorate because their CSF pathways are difficult to reestablish. If you put ventricular drains in, they often clog up, and it takes a long time weeks for this hemorrhage to break up. So Dr. Dan Hanley at Johns Hopkins has done 2 preliminary trials, and he's just gotten funding for $20 million for CLEAR 3, which is a multi-center randomized trial. So the treatment is to place the ventriculostomy, put in TPA, 1 milligram, 8 hours for every 24 hours to try to lyse the clot here and improve the outcome. And it looks promising in this group because, as I mentioned, there's not a lot of parenchymal brain damage. It's mostly to try to clear the CSF pathways. And if you look at an example of a patient, here's a patient with an IVH, and these are the days that it takes to clear the hemorrhage. If you get the TPA in the ventricle, it usually gets cleared within about 72 hours. So that results in a much more rapid restoration of CSF flow and control of the ICP and prevention of secondary deterioration in these patients. Now, the Misti Trial, again, it's counterintuitive when these patients, one of the problems is they continue to bleed when they come in, but this trial is looking at patients after the hemorrhage is stabilized, once the bleeding has stopped, and then to place a catheter stereotactically in the hemorrhage here, and then give TPA with a much smaller dose and lyse this over time to prevent the secondary edema and shift that occurs, because again, these can take weeks to a month to resolve. And so this is an example of a clot that's reduced with multiple injections of TPA through a catheter. And this catheter has to be placed with a stereotactic device to make sure it's right in the center of the catheter. And our study that we are performing right now is in addition to these studies that have been already accrued a large number of patients, and we're adding an ultrasound catheter because of these observations that ultrasound enhances the TPA lysis. We're adding the catheter to the mix to see if we can lyse the clot faster than just TPA alone. So we're just doing a small safety study, and these have to be ICHs of greater than 25 cc's, can be in the third, fourth in the ventricles or a supratentorial location. And we're just looking at some safety endpoints of 30-day mortality, increased bleeding rate, or infection. And the catheter, again, is inserted stereotactically into the clot with the ultrasound catheter. This is the same one that's used intraarterially to try to lyse clots in the middle cerebral artery. It's made by this Echos Corporation. And as I mentioned, there's an effect where it does result in increased mixing of the drug throughout the clot. So this was our first patient we treated, had an intraventricular hemorrhage that filled one side of the ventricle here. It was resulting from a thalamic hemorrhage on that side that broke into the ventricle. We used this stereotactic device to place the catheter exactly in the clot, and we check it with one of these portable CT scanners. So if this ends up working, eventually this may be just be able to be inserted through a burr hole, and actually in the end could potentially be converted to an ICU procedure rather than an operative procedure. So this was the quite an exciting result. Here was the initial clot. Here was the catheter and ultrasound catheter placed in the clot. By the next day, the intraventricular portion was completely gone. So instead of 72 hours, we're talking about clot disappearance within 24 hours with no rebleeding. This was a second patient with a large hemorrhage here. And then this was the catheter placement with the ultrasound and ventricular catheter for TPA in the hemorrhage. With 24 hours of treatment plus ultrasound, you can see the marked reduction. And then 48 hours, all the pressure is relieved here. So there's a little bit of residual, but it's a marked increase in the removal. Here is our third patient with a spontaneous temporal lobe hemorrhage. Catheter and ultrasound catheter placement. This is what it looks like. You drain off the ventricular drain into a bag, and it all liquefies and drains under gravity, so it's a gentle procedure. And this was 48 hours. The clot has nearly completely disappeared. So this is just through a small burr hole. So this, if this hadn't been treated, she may have done well, but chances are that the hemorrhage would have swelled and compressed the brainstem and so forth. And these are the patients that we're always watching because they may have to be taken urgently to surgery. So this is some encouraging information, again, with this sonothrombolysis. So in terms of some of the vascular lesions that we get involved in with as neurosurgeons and some of the things that we end up treating in these patients that come in with hemorrhages, I'll just go through a number of these to refresh everybody's memory. The vascular malformations, most commonly the two here are the arterial venous malformations and cavernous malformations. Arterial venous malformations are thought to be congenital lesions. Cavernous malformations can be acquired. They're lower flow. They don't show up on angiogram, but they can cause bleeding and other symptoms, which I'll go over here. This is a patient that came in, a young man in his 20s with a small intraventricular hemorrhage here. You can see the 2 spots of blood. Spontaneous hemorrhage in a 20-year-old, there's got to be some cause usually. So the CT scan with contrast, again, shows this terrible, huge arteriovenous malformation in the temporal lobe. This is the MRI showing this large tangle of blood vessels. This is the AP angiogram. All this is abnormal here. And the vertebral artery angiogram showing that it goes all the way back to the posterior part of the temporal lobe. This was too big for any radiation treatments, which I'll show you a little bit later, so the only choice was a surgical treatment. So we did a large craniotomy. This is the post-operative angiogram showing that the AVM is all gone. These are the normal vessels filling out. And this is his 6-week visit after surgery. So these can be removed, even though some of these look very, very dangerous. They're all extra vessels in usually non-functional brain tissue. So this is an important thing to look for as a cause of intracerebral hemorrhage. And another example of the location and removal here. So here's an AVM. It's really like a tumor of the blood vessels. We usually embolize these with the aid of a neurointerventional radiologist with particles. This is the normal part of the brain here. And then this is after this AVM is removed. The other main treatment for AVMs, the embolization is just an adjunct for treatment. It's not a primary treatment. But the other primary treatment that we can use, especially for smaller AVMs that are deeply located, is radiosurgery. The modality that's been around for many years that came out of Sweden is the Lexell gamma knife here. And the point here is to try to focus multiple beams of radiation at all low doses, but they converge on a single point that causes a high dose of radiation to the vessels. This causes them to involute with time and disappear. And it's effective about 80% of the time with AVMs. The newer treatment that's available now without having to place a head frame on the patient is called a Cyberknife. And the point is the same here, to pick the AVM target, or this is used to treat brain tumors also, benign brain tumors in particular. The dose is all directed toward that central point. This uses a welding robot to do it sequentially and actually can track the patient if there's any movement. So it's a little bit more comfortable for the patient in that they don't require a head frame, but the principle is the same, multiple sources of radiation to a single point that then cause in AVM, with AVMs for them to involute with time. So the radiosurgery can be done without a craniotomy. They used to treat small or deep lesions. They're ineffective for lesions larger than 2.5 centimeter. And one of the disadvantages is that the surgery is an immediate treatment, so that's done preferentially. The risk is removed immediately after surgery if the AVM is removed, whereas the radiosurgery can take up to 2 years to work, and the patients can be at risk for hemorrhage during that period of time. So we usually prefer to do these only in lesions that are not easily accessible for surgery or that are deep, and in smaller lesions. Cavernous malformations, another type of vascular malformation that was only really more discovered when MRI came, because MRI picks them up so easily. They're very difficult to see on CT and other modalities. They don't fill on angiogram, but they present with seizures, repeated bleeds, or can be focal deficits. The treatment is either observation if they're discovered incidentally, or surgery. Radiosurgery has no effect on these and is not usually used. Here's an example of an MRI showing a cavernous malformation. This is just illustrates some of the advances in technology that we're enjoying now. This is a functional MRI, which shows the motor movement here, shows that the cavernous malformation is posterior to sensory cortex, so it allows us a direct surgical approach with no neurologic deficit. And this was removed, and the patient went home the day after surgery. Here's another one that presented with a focal deficit in the brainstem. These can be in the brainstem. You can see it here. Patient had arm and hand weakness. Here it is at the cervicomedullary junction, right here. Here's the surgery showing. This is the cerebellum. Here is the spinal cord here. This is the obex, fourth ventricle. You can see the discoloration here. And then here's the surgical removal And here's the post-operative results showing the hemorrhage cavity with the cavernous malformation removed. And this patient did very well after surgery. Aneurysms, another cause of bleeding in the brain, most commonly cause subarachnoid hemorrhage, but can also cause intracerebral hemorrhage as a primary event. And as you know, this field has really been revolutionized over the last 10 years with the introduction of the GDC coil, or these endovascular coils that are used here to place up inside the aneurysm. We're currently treating about 50% of our aneurysms with coils, and about 50% still get surgery for various reasons. But this has been a big change in the treatment of cerebral aneurysms. The initial coils were only good for small necked aneurysms because the wider necked aneurysms wouldn't hold the coil in. They would prolapse into the vessels. And now these neuroform stents, or stents that were designed to use in the cerebral vessels, are deployed in conjunction with the coils in some of the wider necked aneurysms, so the stent prevents the coil from coming back down into the vessel in some of these wider necked aneurysms. And here's the traditional clipping showing the three vessels. When the aneurysms share the origin of the vessels, they're very hard to coil because the coils will prolapse down into there. And with a clip, these are two clips here, you can reconstruct the vascular tree here and collapse it from the outside, so this results in normal flow out to the distal vessels. Here's a typical posterior communicating artery aneurysm that was clipped, and a typical subarachnoid hemorrhage. As I mentioned, they can present with intraparenchymal hemorrhages too that can be sometimes mistaken for hypertensive hemorrhages, so therefore a CTA is very valuable in ruling out this as a cause. Here's the axial image of the CTA showing the clot here, showing the aneurysm filling, and then the reconstructed CTA here showing that large middle cerebral artery aneurysm. And here's the urgent surgery that was done with removal of the bone flap here, and then placement of this clip across the large aneurysm with preservation of the vessels here. Clipping versus coiling, again, there have been hundreds of studies now to try to answer this. It's a moving target because the technology keeps changing, but there is a recurrence rate with coiling, about 20% or so, especially with incomplete coiling. The recurrence rate is much higher. So it's better in patients with a small neck on their aneurysm that can be completely coiled. If they're older age, the recurrence rate is over a long period of time, so they may not ever have a rehemorrhage or a problem. Whereas if they're younger age, the clipping is favored because of the long chance that they could have a recurrence, especially if they have medical problems, posterior circulation, poor grade. The acute coiling has shown to be slightly safer than clipping in terms of a short-term outcome. And again, we're trying to see if the long-term outcome with constant surveillance and probably recoiling in some patients is going to be advantageous, and there's obviously going to be a cutoff on a patient's age, which procedure is chosen. So the clipping we still do in patients, usually the ones that are under 40. MCA location is difficult to coil. Large size or large neck, vessel access problems if they have atherosclerosis, or associated intracerebral hemorrhages that need to be removed. Those go for clipping. A couple of other rare conditions that can cause intracerebral hemorrhage or stroke. This is a disease called Moyamoya Disease. This was first described in Japan, but there are a number of reports from all over the world now. The incidence is lower in the United States, but we've reported 60 cases. There have been a report from Texas, also a couple of other centers in the U.S. showing that this condition does exist here. They can present with multiple infarctions or intracerebral hemorrhages. Often we've had patients that have been misdiagnosed as MS. Our population of Moyamoya patients has been mostly young females with strokes. What the Moyamoya means is puff of smoke. So when you get the angiogram, the major arteries have been occluded, and these fine collaterals form what looks like a puff of smoke on the angiogram, and they can, again, these can bleed and cause hemorrhages in the brain or can cause a stroke. What happens is there's an idiopathic narrowing of the carotid termination. There's fibrosis, very little inflammation. There's contraction of the elastic lamina, thickening of the endothelium, and these vessels eventually go on to thrombose off. And the collateral vessels are formed to try to increase the blood flow around these. So here's a patient that we had recently presented with an intracerebral hemorrhage. This is the severe narrowing on this side, an occlusion on the other side with these little puff of smoke, collateral vessels being formed. So the treatment that we do for this is revascularization or bypass procedure. Here's a superficial temporal artery to that middle cerebral artery. Here's a superficial temporal artery on the other side to the middle cerebral artery, doing the bypass procedure. And that is the standard treatment now for ischemic disease. For stroke, it's still controversial, or for intracerebral hemorrhage, it still hasn't been definitively established whether it prevents hemorrhage. Here's a patient with an intraventricular hemorrhage. Again, the CTA was the key to this diagnosis. When we got the CTA, we found both middle cerebral arteries were occluded here, and these are the Moyamoya vessels. She went on to have a bypass procedure. Here was a patient that developed an ischemic stroke from the same disease here. So it's a race between the collaterals forming to catch up and the ischemic changes. What happens is these normal vessels, this is the middle meningeal, become hypertrophied. You can see these little collaterals forming at the surface of the brain. This actually shows the vessels actually grow through the skull right here to try to recollateralize the brain. And these are late changes in Moyamoya where the internal carotid arteries clot off. So the bypass procedure takes the superficial temporal artery. This is what's called a synangiosis procedure, where the vessel is laid on the surface of the brain and grows in over time. This is more commonly done in children because the vessels are so small it's difficult to anastomose. And this is the direct suture bypass, where the superficial temporal artery is dissected out and then sutured to the middle cerebral artery branch. And this is showing this bypass in a patient with Moyamoya disease. Here's the bypass vessel here going into the middle cerebral that's severely narrowed at its origin right there. Last thing, as you know, tumors are another spontaneous cause of intracerebral hemorrhage. So one of the things we have to do, as I mentioned, is to rule out other causes. This is a young patient with a tumor that hemorrhaged, so it's not a primary intracerebral hemorrhage, but does have another cause. The last thing, decompressive craniectomy. This can be done, this is often done in trauma, and there's been a lot of interest in stroke. A number of trials have been done because of the observation that in younger patients, especially the ones that develop a right hemisphere stroke, then are awake for the first day or two, but then go on to swell and herniate, does the decompressive craniectomy result in a better outcome? So there's a study that was just published last month in the Lancet Neurology, this Hamlet study, where they looked at the effect of this done for patients in this category. And it turns out that it actually does, if it's done within 48 hours of their symptom onset. The overall trial was negative because it included all the patients, but the subset that was done within 48 hours of the onset of their symptoms actually had a better outcome in terms of a 50% reduction in their death rate and improved Rankin score. So there are very few excellent survivors, but many of them, there's only a very small number of very good outcomes. Most of them will have some deficit, but it can be a life-saving procedure in the ones that have minimal primary brain damage. And the three trials combined here show that the ones that were done early, within 48 hours, have a better outcome. Cerebellar infarcts, again, this is a neurosurgical problem when the cerebellum infarcts because of a posterior circulation artery thrombosis. These are an acute surgical emergency when they swell up, and the results are very gratifying when you remove that. So in conclusion, in terms of neurosurgical approaches to stroke and hemorrhage, for the ICHs, the important thing is to determine the cause. We're always called to consult on these patients, rule out a treatable vascular lesion, try to stabilize the ICH, get the blood pressure, get the coags reversed, Evacuate surgically for mass effect in the better patients that are not devastated by a deep bleed. As I mentioned, the results are better in surface lesions. The minimally invasive approaches show some promise. And then, of course, there's risk factor control if they're due to hypertension. And there have been a lot of new treatments that have come along, in both the medical and surgical treatments for stroke and ICH. And sonothrombolysis is looking to be promising for both the ischemic and the hemorrhagic type, and we're very excited about some of the trials going forward to see if we can improve the pool of patients that are available for treatment with TPA for acute ischemic stroke. There are continued developments of endovascular treatments. Radiosurgery now plays a role, and so physicians from multiple specialties, including radiation oncologists, neurosurgeons, stroke neurologists, as well as endovascular specialists, are all getting involved, and to the benefit of patients in most cases. And I think I'll stop there, and thanks very much for your attention. Yeah. Yeah, we have a few minutes for any questions, comments. Yes. Excellent question. In fact, Dr. Reisman, who's doing the trials, is in our medical center, and so there's been a lot of interest in PFO for complex migraine and also for stroke. They just completed a trial in patients with stroke of undetermined etiology with PFO, and they were randomized to either best medical treatment or closure of the PFO and medical treatment. And I'm trying to remember what the acronym for that trial, Closure 1, I think it's called. And the results are in they're being analyzed right now, but they have not been released to the public. So that should be coming out within the next year or so, whether, preemptive closure in these patients is the right approach, or wait till another event comes along. Or give Coumadin or, medical treatment to prevent clots. The closure devices are getting better and better and safer, and so the morbidity of that closure procedure seems to be going down. So I think there's hope. Some of these bioabsorbable sutures are being developed now, where it's all done endovascularly. There used to be a diaphragm type device that went across the defect, and now some improved methods to closure are being developed there too. Yes. It still is. Unfortunately, it's been one of those. One of the neurosurgeons, I forgot who it was, gave a talk on these unsolvable problems in neurosurgery. Chronic pain is one of them. Recurrent, failed back surgery, and vasospasm. It's been worked on for 20, 30 years. The only drugs that have really been shown to be any good are the calcium channel blockers, nimodipine, but it doesn't really help in all patients. They've been looking at statins, new endothelin antagonists, and so forth. The drug that works, the calcium channel blocker, only works partially. We still have to go to angioplasty and other treatments in patients with the severe bleeding. So it's a problem that still hasn't been solved. I think the outcome is a little bit better with cerebral angioplasty, where you can put a balloon up and dilate the vessels. That's certainly been shown to improve blood flow and improve the circulation in patients with spasm. But no completely effective treatment has been developed yet for it. Well, thank you very much.